So welcome back to FKB Physio Podcast. Today I have my friend Lewis with me. Lewis was actually my first guest on my podcast. I have him back to talk about osteoarthritis, and I know that Lewis is very up to date on his clinical reasoning and explanations for things, so that's why I've got Lewis here. We're going to be talking about osteoarthritis. So there are other types of arthritis like rheumatoid arthritis or psoriatic arthritis. That's a hard one to say. There's heaps of different types of arthritis, but osteoarthritis is sort of probably the most common one. It's the one you think of when you hear the word arthritis. So that's the one we're going to talk about. And just as a side note, the difference between osteoarthritis and osteoporosis I think is important to bring up straight away as well. Osteoarthritis is more of a joint related condition, whereas osteoporosis is a brittle bone condition. So it's more about your bones becoming sort of less dense. And I've done other podcast episodes about that. Osteoporosis doesn't hurt. So it's a silent condition to have. You often don't know about it until you've had a bone fracture or another complication, but it won't be joint pain. So now that I've said all of that, I will head over to you, Lewis, to ask you, what is osteoarthritis?
Well, firstly, thanks for having me back on.
No worries.
I think with this topic, I very much stand on the shoulders of giants, as they say. So I'm going to defer to a physio by the name of Jack March, who's an expert in rheumatological conditions.
Mm-hmm.
And he once tried to define osteoarthritis in a tweet.
Yes.
So nice and succinct.
Yeah.
He said, osteoarthritis is joint-related dysfunction with an extremely complex interplay of causative factors ranging from aging and obesity to joint injury and genetic susceptibility. There are some associated changes, but these do not appear to correlate with symptom severity. So I found that like a very, it's a beautiful summary. So osteoarthritis is essentially joint pain.
Mm.
Okay, the symptoms include, as I said, pain, swelling, and stiffness.
Mm-hmm.
There is often a activity-related sort of behavioural pattern where either prolonged periods of immobility or inactivity or a period of overactivity can be associated with this process of pain and swelling.
Mm. Okay, is there redness usually in the joints?
Again, I wouldn't say usually. You can have it if the inflammation is particularly profound, but I don't think that redness is necessarily like a super common feature, although I have seen it.
Yeah, and I think it's important to note that a part of osteoarthritis is there is joint changes, and so extra bits of bone can sort of get laid down as part of the process, and that can mean that people's joints actually physically truly have less range. And I wanted to bring that up because a couple of my clients with it, I have some who have, I think knee arthritis is the easiest one to talk about, so I feel like a lot of this is going to be referring to knee osteoarthritis. They either have pain and they know they have knee osteoarthritis because they've had imaging, or they don't have pain but they know they have knee osteoarthritis because they have really significant loss of range, like they can't bend their knee more than like 90 or 100 degrees. And a lot of them feel like it's their fault, and they think that if they do mobility exercises, they can get it back. And I think it's important to sort of point out that a part of the condition is that it does actually change the structure of your joint. And so... Yeah,
absolutely. There are imaging changes that can help with, I guess, diagnosis. However, I think nowadays the lean is to steer away from imaging and make the diagnosis clinically. So just based on how you present your signs and symptoms, we can say with a fair degree of confidence that you have arthritis even without doing a scan. But yes, there are some joint changes. So you get a loss of cartilage thickness and occasionally areas of partial and full thickness cartilage loss. And that's where the common description that I hate, bone on bone, comes from. And while that may be technically true that there are areas of the bone where there's no cartilage overlying the subchondral bone anymore, no joint can be completely bone on bone. There's always synovial fluid separating the long bones, which acts as a cushion and a lubricant, so that will kind of fill in that defect and reduce the contact pressure. So I think some people get this idea that there's no cartilage remaining at all. I've never seen that in my life, and I honestly can't see anyone who's completely bone on bone.
Yes.
You can also get some bony sort of overgrowth around the margins of the joint, as you said, and some subchondral sclerosis and cysts.
Yeah.
But the reason we steer away from imaging is it doesn't necessarily do much to tell us about how severe a person's symptoms are. So a worse looking scan does not mean worse pain, worse swelling. Generally speaking though, yes, some of this bony overgrowth and loss of cartilage will come with a reduction in range of motion, as you said, and it may mean that there's always a ceiling on how much the joint can move.
Yeah.
But that doesn't mean that you can't just maximise what you have.
Yeah.
And it doesn't mean there's no capacity for improvement. It's just to set realistic expectations. It may never move like the unaffected side. Yeah. But we can definitely try and maximise that through activity.
Yeah, and I think that's awesome. And I do think it's interesting that a number of the patients I have who mention that they know in passing that they have it, or I'm actually thinking of a few people that have never been diagnosed and they don't have knee pain, but when I'm trying to get them doing like low squats in my classes, and say they're over 50 and they're really struggling, and I go to check their joint range and they don't actually have that much, it's quite interesting because I'm thinking, well, there's probably some changes going on there, but since I don't have pain, again, exactly what you say, I'm like, let's just maximize what you've got. But I think it's interesting just to recognize the ceiling, because I think sometimes those people think, oh, well, if I just keep training, I'll get full mobility, which if you are over 50, 60 and it's already significantly less, like there probably is a ceiling effect. I think it's important to recognize that.
Yeah, definitely, and you know, it's hard to know where the ceiling is without giving it a bit of a nudge, though. So you know, I'll never tell people that, you know, there's no chance you'll see any improvement, but it's also really, you've got to be honest and upfront at the start. There is a chance it may not move like the other side. Yeah. That doesn't necessarily mean that you'll have, you know, pain and swelling associated with that, but we've got to be realistic at the end of the day. And
why do you think it is that clinical symptoms don't necessarily match the imaging? Like, what's with that? Because I'm sure you've had patients as well that have technical bone on bone, but they don't have pain. Why is that?
I think it probably has to do with, again, circling back to Jack March's definition, there's far more to it than just the joint structure. Yeah. More and more we're starting to see that like the neuroimmune system probably plays a role with respect to like ramping up inflammatory markers within the system. So perhaps there are some other factors in the person's lifestyle and general health that may be predisposing them to having this painful joint. Yeah. And I do think that, you know, for some people, perhaps the level of activity that they engage in is just protecting them from symptoms to a degree. And it's very difficult to say with absolute confidence as to why advanced joint changes don't correlate with symptoms. But I think it is handy for people who are, you know, angling for imaging. The only reason to do it is if there's any doubt about, well, could there be something else going on here? And that's where a scan can be useful to clarify. But we also should put, you know, grain of salt with respect to how bad things look on the picture. Yeah, because again, like I've had so many experiences with clients where often at least it's someone that's had a scan and then they saw it and they're like, that's weird, the scan's terrible, but I feel fine. Like it's, you know, they've gotten the scan after things have already started improving and they have that experience of, oh, I can see that it's not related because I've seen the scan, but I can feel my knee. I've had so many of that, but it's tricky when someone's got new onset knee pain and they go and get the scan and it looks so bad and then they sort of freak out. Yeah, and I think too, again, circling back to what some common misconceptions are about osteoarthritis, you know, we've got this idea of bone on bone and you know, wear and tear and concepts like that, and I think it's totally reasonable for people to think, oh gee, that sounds really
And it's like all downhill from here.
Yeah, and when we actually look into the data on this and how does osteoarthritis symptoms tend to change over time, it's actually not as progressive a condition for the majority of people as you're led to believe. It's not a case of, oh, you'll eventually need a joint replacement. Yeah. It's a surprisingly small amount. I believe I heard a podcast recently with a world-renowned expert in osteoarthritis, and he said, you know, it's around 10% or so that need a hip or a knee replacement. Yeah. And the symptom trajectory over many years, and we're talking decades, is fairly flat. Yeah. So it's not guaranteed to just get worse. Some will, to be frank, but I think that you're sort of putting the cart before the horse and you just assume, oh, I'm destined for a joint replacement, or this is only going to get worse as I age. It could just be a very stable annoyance in your life. Yes.
And on that note, Lewis, as someone who possibly has had some personal experience about you just mentioned that the only reason to get imaging might be to rule something else out. And you've also mentioned that it might not get worse over time. So you've had a situation yourself with your knee?
Yeah, so I actually have patellofemoral arthritis in my left knee.
That's like the kneecap joint.
So the kneecap joint, the joint between the kneecap and the end of the thigh. So, and that stems from, and I know we're going to talk about risk factors in a few minutes, but it stems from an old basketball injury where I subluxed my patella at 11 years old, I should say, and then over the course of playing basketball on that knee for many years, it sort of I think, and again, quite a high amount of use year round. I have developed patellofemoral arthritis as a result. Now, one of the things that led me to get imaging was I started to experience some very strong mechanical locking within my joint, where it would get caught in place for potentially hours, where I couldn't bend or straighten very far, and then eventually it would come loose, and I sort of found what appeared to be like a small lump at the top of my joint at times, and it turned out that I developed a small loose body that was about the size of a tooth within my joint, and that was getting caught. So again, in situations like that, yes, imaging is important to confirm that is indeed what's going on and to rule out anything else going on there. And I have benefited a lot from having a knee arthroscopy to take that out. I've had none of those symptoms since. So situations like that are certainly
But did you also, I feel like, of course, and then I think you've also posted about how you have had an MRI that showed, or a scan or something that showed the arthritis, and your symptoms a few years ago were much worse than they are now.
Correct.
So you've actually improved your symptoms.
And I'd say too, again, the way my knee feels right now is probably better than it did 2.5 years ago. I'm probably more active at present as well. So I'm doing a lot more running, I'm doing some sprinting, I still lift weights, and yet my symptoms have not gotten worse. It's not just that whole, it's a ticking time bomb, and again, what the future holds for me, I don't know, but I personally don't feel like I'm destined for a knee replacement. Yeah,
well, that's good news. I hope not as well. We are still in our, are you 30 yet?
I am, yeah, I'm 30.
We're still not good, but fingers crossed. I guess watch this space, we'll do a podcast in 60 years time.
Absolutely. I'll be very candid about the experience. But look, I think I feel optimistic.
Okay, so I was going to go through the risk factors because you just mentioned previous injury is a big risk factor for developing osteoarthritis. So, and it's usually a joint injury that causes damage to the joint surfaces, right? Like it has to be something that actually disrupts it inside. So a really big one is like an ACL tear of the knee. But also, I think it is important to say that something like a joint arthroscopy, because they're going inside the joint and poking around in there, that is a risk factor too. Just when people are considering that, obviously, if you had a loose body in there, it's absolutely necessary. But it's just something to think about, because I don't know if people necessarily think of that.
Where I land on that.
This
is my understanding at least, it's more when you've had an arthroscopy to do a meniscal debridement, or they call a cartilage cleanup. So if they're actually taking things out,
that makes sense.
Taking out pieces of your meniscus, or trimming edges of cartilage, they may be accelerating that process. If it's merely we go and we take out a loose body and we don't touch anything else, which is what I had, I don't really know whether or not that will predispose me to more risk, but logically speaking, because everything else remains intact, I would like to think that
hopefully not.
That's fairly benign, but certainly the example of your ACL injuries and what we know is that having an ACL reconstruction may actually make you a little bit, a tiny bit more prone to knee arthritis than if you didn't. And that's because that is, not only have you had the joint trauma of the ACL tear, you then have further joint trauma of them drilling holes to put your graft in, and that clearly has an effect on the joint over the long run as well. Yes,
and the same is true for meniscus, like what you said. If people have a meniscus tear and they go and get it cleaned out, that has been shown to be an increased risk, right?
Yes, definitely. I don't believe that's the case for meniscal repair, although I think there's limited data on that, but certainly for meniscectomies and the larger the piece of meniscus that they take, the more likely you are to have arthritis. Yeah, okay. And then age is obviously a big one, so the risk increases with age, and mostly it's sort of people as you get towards late 40s into the 50s, but it can happen at any age. Obviously you're 30 and you've got some there. I hate to even mention it, but what should I call obesity, overweight, whatever the appropriate term to use is, it is associated with increased risk of developing osteoarthritis, and it's not because it puts more load on the joints. People say that all the time. Even when I was looking up stuff for this podcast, there was this little statistic that was if you lose this much weight, it's this much less load on the joint, and I think that's
not necessarily how it works. I think the thought is more that it's that increased body fat might lead to increased general inflammation, which, as we've already said, osteoarthritis has this inflammatory component, and people with it have been found to have a higher rate of inflammatory protein in their blood. So it might actually be more relating to that than that, you know.
Yeah, it does seem like there's a strong metabolic contributor to the development of osteoarthritis. And one of the other things that I find really interesting is that people who are obese are actually more prone to hand and wrist arthritis.
Okay, yeah.
As well. So again, they're not walking around on their hands, and I struggle to see that they're overusing that to the degree that it's so much joint pressure. You know, none of us are putting our full body weight through our hands that often, unless you're doing handstand walks. Not many people do. So that definitely underpins that idea that, you know, joint loading is not necessarily it doesn't increase your risk as such. So I don't think that's the reason for the increased risk in obesity. I think it's far more down to metabolic processes and the way it affects inflammatory chemicals circulating in your body.
Yeah, and I think important to say here too as well is that, like we discussed before we started talking on the podcast, making lifestyle changes can have a positive effect on that low-grade inflammation. So I think it's a really sort of, what would you say, like a not very good piece of advice that people often get. They've been diagnosed with osteoarthritis at the doctor and they're just told, oh, you need to lose weight.
Yeah.
Especially considering how hard that is. Like, I never go there with patients anymore because, well, I don't think I ever did, but I'm even less likely to now because I just think, you know what, it's such a difficult thing. It's so hard, and most of the time telling someone to lose weight won't cause weight loss. So it's sort of like not an area I want to go into, but you can make these positive changes. Like if you start exercising, it has a positive effect on inflammation, quality sleep, stress management, good diet, you know, those sort of things, they can have this positive effect. So if you are someone who has, like, you know, you're at a heavier body weight and you know that that's just you and it's really unlikely to change, don't feel disheartened that...
No, and again, I can tell you from my own clinical practice, my own experience, I've treated some people in larger bodies who have got arthritis, who see symptomatic improvement through making some lifestyle changes without losing weight.
Yeah.
Now, while weight loss we know it can be helpful, it's only one potential avenue for improvement, and there are other options. So I personally think it's really lazy care. And I think that to just say, oh, you're just overweight and you should lose this much weight, I think that's very reductionist. I think that it's you know, a cop out by many clinicians who should be looking into other avenues for improving a person's symptoms. It also, not to go off on a tangent, it probably speaks to the, you know, the stigma that people in larger bodies face trying to access healthcare, and probably again creates very negative experiences where they don't feel heard and they're not given good quality care. So I think if that's all your clinician has to offer you, I think you should try and find someone a bit more informed.
Definitely. Okay, and then there's a few other ones here. I'm not going to say some of them because I don't like them. I got these risk factors off the arthritis.org website, but anytime you go on websites like that, there's always words that I feel like they can be misinterpreted. So I'm just going to skip a couple here, but genetics is a big one. Gender, unfortunately, women are more likely to develop it, as always. And then it's sort of listed as environmental factors, but they're things like having a previous injury to the joint. And I wanted to just talk about that one a little bit more because a lot of people listening probably have had a previous injury to the joint, and if you're someone who's relatively young and you've just heard for the first time that your ACL injury might mean that you're at more risk of developing arthritis, and I'm actually just thinking of all the clients I have coming to my bone density classes and how many of them actually have had ACL reconstructions, you might be thinking, oh no, I've had one, what can I do to reduce my risk of getting osteoarthritis? There has actually been a recent study done to look at the recommendations of experts for that exact question. The OptiKnee study, it was done last year, and the advice that people were given was basically, again, and I don't want to bring it up again, but one of the recommendations was just to be aware that a higher body mass might increase your likelihood of having arthritis or symptoms from arthritis. So all I can do is report that that's what the study said, but we've already kind of covered that. And that inactivity is negatively associated with, I don't think you can prevent arthritis, but inactivities may increase your chance of developing symptoms of osteoarthritis. And it's had a very sort of not specific recommendation as well, that weakness of the thigh muscles is also something else that's not necessarily helpful. So I guess what I would take from that is, okay, if you're younger and you want to reduce your chance of having symptomatic osteoarthritis, the best things to do would be to try and be as healthy and active as possible. That's sort of like the basic thing I can take from it. And I guess it's just something that comes up in the research over and over, that exercise is like a really big thing. So is that what you would say you've been doing with your knee?
Yeah, I mean, taking off my just physio hat and speaking as someone who has knee arthritis, that is very much the avenue down which I'm sort of taking things. My goal is to just continue loading and using my joints within what it can tolerate. And I suppose, again, trying to avoid those things that I know will contribute. So certainly trying to, eat well, continue moving. I think we've also got to, looking at this from a very zooming out and looking big picture, things like sleep, things like stress, other things like, I dare say, smoking as well. All those sort of factors are probably like, I think what everyone should think is, to quote Greg Lehman, how can I be healthier? How can I be healthier? And I think if you're taking steps to be healthier, you are probably going to mitigate the impact if it does develop, or I mean, in some cases you may prevent it altogether, but at this point it's impossible to say. I would not tell anyone with any confidence that we can avoid it 100%.
No, but I think that just try and be healthy thing's really good. And I guess something I notice heaps is so many of my clients, they have had a knee injury and they specifically are like, I need to not load that knee because I've had an injury. And I often see these people like years and years later and they haven't come in with that. They're just mentioning it in passing. You can see that their muscles on that side are much smaller. And it's funny because I'm just thinking, I personally would have done the exact opposite. Like I would have been like, I really need to strengthen that side because it's had an injury. So I think, and it makes sense, like the people who've been told wear and tear, you need to rest your joint, you need to offload it. Like that's the dominant narrative still. So I guess I feel like this is part of why I wanted to do this, was to reinforce the idea that you actually need to load it. Yeah. And that's good for it.
And I guess like, and I know that there's been some stuff recently that probably calls into question the overall effectiveness of exercise to treat osteoarthritis. So I'm definitely going to put that caveat in. We can't guarantee that exercise will eliminate the pain.
No, of course not.
But with that being said, it is still recommended as a first line treatment. As part of, a broader picture approach. So I think that in and of itself should reassure people that it's safe. But I think we can look to some of the research that's been done on people with arthritis and how they use and load their knees, and it probably can put to bed some of these notions about, it's wear and tear, it's purely load, it's only going to get worse. So I know you've got a systematic review there about runners. So
great segue, Lewis. So like Lewis just said, and this is perfect because I did want to talk next about is exercise safe for osteoarthritis, and most exercise or most guidelines, like clinical guidelines, there's these things that come out that tell people, GPs, physios, everyone, they tell all of us sort of what should you recommend if you have a patient with this condition, and exercise is always the number one thing for osteoarthritis. One of the big reasons is because it's low risk, and it's just compared to invasive things like injections and surgery, the risks of exercise are really low, and then it also has all these benefits on your health as well. Like it might reduce inflammation, it might help comorbidities like blood pressure, it might improve your bone density. Like it's just this definite thing that you should do. So obviously I'm a huge exercise advocate. So the first sort of thing to say is yes, exercise is safe if you have osteoarthritis because it's the number one guideline. But I think people might not, I don't know if that's very powerful for people to hear that.
Yeah, I think too there's a misconception that everything you do should be very low impact, joint friendly stuff. That's probably where we can really debunk that quite easily.
Right.
They think, I should cycle or I should swim or I should do something that isn't jolting my joints, but that's not even what the data would suggest. So I'll let you go from your...
I did have a look. Because I know there's a lot about runners, because everyone sort of says running's bad for your knees. It's like the standard narrative. There is a systematic review and meta-analysis in one of the sort of bigger orthopedic sports physical therapy journals out there. I will put all the references on the notes in the podcast. And it looked at the rates of osteoarthritis in runners compared to sedentary people. And it was like huge. It had thousands of people in there. So 3.5% of recreational runners had knee osteoarthritis compared to 10.5% of sedentary people. So less. Must be said that they found that for elite runners, and I think you read the same one, and it said that elite meant like competing on an international level.
Yeah.
Those people actually did have slightly higher rates of 13.5%. But when I was reading it, it was sort of saying that those runners were doing in excess of 92 kilometers a week. And I guess just bear in mind too, like if you're a competitive athlete, you're going to be really pushing the limits, and if you're injured, you're probably just going to like keep going. It's completely different to a recreational runner, and most of the clients we see, no one is going to come close to the levels of exercise you have to do for it to actually increase your risk of arthritis.
And keep in mind too, the recreational running group, they were still partaking in distances up to marathon distance, so they're still doing a lot. They're still doing a good amount of running.
Yeah,
they're still doing a great amount of running, and yet they have a lower predisposition to hip and knee arthritis versus sedentary people. So it seems like there's a big sweet spot between sitting on the couch and pushing the boundaries of human performance.
Yeah.
And if you're somewhere in the middle of that curve, you may be reducing your risk.
So good.
The other one that I like to talk about was a really interesting prospective study of people in their 50s who run and have knee arthritis.
Yeah.
And so what they did was they actually scanned them at baseline and then again 48 months later. Yeah. And they surveyed them for their symptoms to see how bad their knee pain was.
Yeah.
And what was really interesting was, and they were doing self-selected running, so not prescribed. They just said, whatever you want to do in terms of running, like we want you to carry on doing that. Over the course of 48 months, continuing to run was actually associated with an improvement in their pain and no change on their scans. So there are ways that we grade the severity, even though we've already talked about how scan results don't correlate with severity, but they can talk about more advanced arthritic changes, and none of them had progression of the cartilage loss or the joint space narrowing or whatever you want to call it.
That's so cool.
And they all had less pain.
Yeah.
The other thing to highlight too is that I think people often think about joints almost like this inert, like a door hinge that's eventually going to rust and break down, and that's where this wear and tear ideas get really sticky. But if we actually look at it, like cartilage does have some adaptive capacity. It can actually, there's some evidence for mechanotransduction, so it seems to actually respond well to the right amount of physical loading. So I think in kids, more vigorous sports participation is associated with thicker cartilage. I know there was a 10-week study done on novice female runners that showed that their cartilage content actually improved by starting to run. So it does seem as though it's not this inert substance that just breaks down with use, and rather there might be some positive changes associated with moving.
Yeah.
What we don't know is what is the ideal dose.
True.
So we can't say with confidence that this much is good, there's the line, you tip over that, you'll damage things.
Yeah.
I suppose the only other one that I'd raise, and I know you weren't familiar with this one, but I'm just going to pull it up now because it's one of the cooler things I've ever seen.
Yeah.
There was actually a study done on during an ultra marathon.
Yeah.
Where I'll just pull it up. So these 22 subjects were doing a 4,486 kilometer transcontinental race.
Yeah.
Like a crazy long race over many days.
Yeah.
And they actually towed an MRI machine around with them.
So cool.
Over, day by day over 64 stages. Mm-hmm. And what they did was they scanned these guys at the start and then throughout the race and then at the end to see what happened within their cartilage. And what was fascinating was not much happened.
Crazy.
So some of them had little osteochondral defects, so areas where the cartilage had thinned prior to the race. Yeah. They didn't get worse.
That's just
from
crazy.
A crazy amount of running. They didn't get worse, and no one got a new one either. So it didn't break down. Yeah. There was a minor thinning response, but then it kind of bounced back as well. So, it was minimal.
So cool.
And I think there were 4 people that pulled out, and it had nothing to do with their knees.
Yeah.
So this again,
I can imagine, yeah.
And we don't know. It'd be interesting to then follow them up in the months after the race to see what the more chronic response to that much stress is. But it's just fascinating that even existing cartilage defects didn't break down further during the race, and if anything, it got that they sort of said that there is an adaptive ability of the cartilage matrix to reorganize and respond to that much loading. So I think if you take all of this together, it's not really fair to call it just wear and tear.
No,
it's
not
guaranteed
at all.
to get worse. I think it's really cool.
Yeah, and I guess it's that thing I've talked about before, where the human body's so good at just adapting.
Yeah.
There was one last thing I wanted to talk about, but we didn't get to this organically, so I'm just going to bring it up, which was just thinking of a few women in my classes this week who got knee pain. They developed knee pain after doing heaps of stairs, or we did increased squats or whatever in the class, and then they got knee pain. And I sort of was thinking about why, and knowing this podcast was coming up too. And I guess I just sort of thought of it they don't necessarily have osteoarthritis, we don't know, we haven't had a scan, but they don't really have symptoms of it necessarily either. But they're in their late 60s to 70s. And I suppose the thought I had was that their joints probably just didn't have as great cushioning as they might have when they was a teenager or in their 20s. We sort of know that with age, things do get a little bit thinner, I guess, a little bit maybe frayed around the edges. And so that might mean that their buffer to cope with a sudden increase in load is just a little bit less.
Yep.
And I just really think that's important to drive home, I guess, because it sort of can be really scary when your knee all of a sudden is really, really sore and it swells up, and it can be really tempting to go, I shouldn't have done that, I overloaded it. But it's more that graded.
Yeah.
It's always comes back to, okay, it was a bit too much for what you were ready for right now.
And that is an important point you raised, because despite the fact we just harped on for ages about how running seems to be good for our joints, I'm not going to take someone who's never run and say, go do a couch to 5K right away.
Especially not. Do you reckon as they get older to you even? I get more conservative with how quickly I up things depending on someone's age.
Correct. And again, it's about understanding that, yes, as you said, a lot of asymptomatic people, so people without joint pain, will actually have some underlying changes consistent with arthritis, and that may just reduce their margin for error when introducing a new activity. So, in the past, in their 20s, perhaps they could have gotten away with doing, 5K out of the blue, and maybe a bit stiff and sore, but more muscularly than anything. When you are a bit older, your joint may not tolerate that as well. But that isn't to say that over the course of, say, 3 months to a year, they couldn't build up to that. But it is about getting the progression right.
For sure.
And I've heard many a story and dealt with a few people myself who took up running in their 50s, 60s, even 70s, and lived to tell the tale. So again, it's just about a sensible approach, and it's going to differ based on the individual. But certainly, your buffer for being able to overdo it with the presence of these joint changes may be a little bit lower. So you just want to think, it's not that I will never do it, it's just that I need to build up steadily and see what happens.
Okay, so the last thing was just, if people have been diagnosed with osteoarthritis, what should they do? And I guess we've talked about things like the number one thing is try and be healthier and do exercise. But I suppose there are other options out there like joint replacements and stuff. So did you want to just talk a little bit about that?
Yeah, definitely. So joint replacements, for people who have tried every other approach and seen either deterioration of their symptoms or no improvement with quite bad symptoms to begin with, there are a number of people who are great candidates for joint replacements and who would really benefit from a joint replacement.
Definitely.
And the outcomes are fairly good from those. I know that there is some data that says that they can be hit and miss, but I do think that for people who tried everything else, who it's a quality of life issue, they will benefit. Now, I think part of the problem, though, is that with the way our system is now, the rates of them are going up, but also you're getting people who weren't offered the alternatives earlier. And so I think that is the problem. It's not that a joint replacement is inherently evil. It's that they may be jumped to a little bit too quickly. So there could be some people that would benefit from lifestyle intervention first, and they may never require a joint replacement. But at the end of the day, if you've got someone who's ticked all the boxes and tried their best, and they are really suffering, they do have a case for it's deteriorating, then we should consider that.
Yeah, definitely.
I think in terms of injection therapies, which you sort of brought up before, I tend to advise against cortisone.
Definitely.
Steroid use.
Me too.
They do seem to be toxic to cartilage cells.
Yeah.
So while it can have a profound effect on pain in the short term, you are probably worsening the underlying process going on.
Definitely.
And potentially just kicking the can down the road, so to speak. So I steer people away from that. As for other things like, PRP injections, as for other things like, what do they call it? Visco supplementation, so where they do the Synvisc gel. I think the jury is very much out on how effective those things are. They're far from a slam dunk. Anecdotally, I can tell you of a few cases I've seen who've had them who did see a substantial improvement in their symptoms. But it wouldn't be my first line recommendation.
No.
I think it's probably more for some people to consider in the event that they're looking to avoid a joint replacement and want to sort of, alleviate some symptoms. But I would still be trying other things and wouldn't be routinely offering that.
Yeah.
The only other thing maybe worth mentioning as well, bracing.
Oh yeah.
It's not something I routinely recommend.
It's so hit and miss.
It's very hit and miss, and as well, I don't want people getting the wrong idea about the brace is the only thing holding my joint together.
Oh yeah.
The way I see it is a brace might just help decrease your symptoms enough to exercise and move a bit more, which might then, or whatever other approach you're taking just day to day with your function.
Yeah.
That you can kind of get on with stuff a bit better, and that might just be like a little kickstarter. But no, I don't routinely recommend that either.
Yeah, I don't either, but patients always ask, and I guess I've had some. I have some where almost the powerlifting knee sleeves when they're training, and that helps. It's just like compression, I guess.
It's just like you're giving your knee a hug, I think.
Yes.
That's the way I look at it.
Yes. Did you want to mention, so you were saying you have a, client, colleague, who's very young, who's had a hip replacement recently, and you had a specific point you wanted to sort of mention about, there can be some harm in people deferring the procedure as well. It's this really, I see it too, in that people have this really non-nuanced idea of surgery is bad, and then they're sort of that's it, surgery is bad, I'm going to avoid a hip or knee replacement at all costs, especially if they're younger. And I get it, especially knee replacements, I feel, because they're a bit more restrictive, but it can be to their detriment.
Yeah, I think, look, at the end of the day, there's this idea that there's such a thing as too young, and that's even perpetuated by surgeons and doctors. They'll say, you've got arthritis, we could do a knee replacement or hip replacement, however, we want it to last, so we're going to put it off for a while, and you should just put up with this for as long as you can before you get that done. So there's no such thing as too young. If your symptoms are bad enough and you've tried everything else and nothing is effective, you can't get it to a manageable level, and you can't engage with the things you want to do, it's reasonable. And the person who I'm currently working with, who's a friend of mine, he's 31, and he's just had his hip resurfaced, which is it's a form of hip replacement. And so the thing is, the modern components that they use actually wear very well. Okay, cool. So they last a lot longer than they used to. The fear was, if we do it too early, we're going to have to revise it 2 or 3 times in your lifetime. Yeah. Based on some of the data that's emerging, my friend, he may not need one until he's very old, if at all. Yeah. And that, he's also going to be able to do things like jogging, and he's going to be able to do things like he competes in boxing. Yeah. So I think that the downside in his case, where it was getting to a point where it substantially affected his quality of life, you think of it from how does severe pain and not being able to do the things you want to do affect us? It really affects our quality of life, and you think about the secondary health harms of not being able to exercise enough. So if you kick that can 10 years down the road, it's 10 years of inactivity. Yeah. It's 10 years of potentially getting weaker. Yeah. Becoming less and less healthy, less robust. By the time you finally get it done, if you put it off from 50 to 60, your functional reserve is far smaller.
That's such a good point.
So from my perspective, there is no such thing as too young. It's how bad are your symptoms? Yeah. Have you tried other things that didn't work? And if that's the case, then there's no reason not to do it. It actually drives me up the wall. Yeah. I think that's
a really good thing to kind of finish on. Okay, so just final little point would be osteoarthritis. It's a joint condition. It's not related to brittle bone, so it's different to osteoporosis. The main thing to do if you think you're at risk or if you're already being diagnosed is to try and improve your general health. So more exercise if you can. Just general health factors like your sleep, your diet, those sort of things, they're likely to help a lot. Exercise is safe. you're not going to wear out your joint by loading it. In fact, loading your joint is good for it. It might help your cartilage health. And if you are struggling with figuring out how to load your joints safely, if you do have osteoarthritis or just joint pain, physios and exercise physiologists are here to help. So Lewis has his own business in Wynnum at Rebuild Health and Fitness. It's a CrossFit gym, right?
Yeah, that's right. Yeah.
And I obviously have mine in Bowen Hills and the Valley. We're both in Brisbane, so there's a north side option and a south side option if you do need to get in touch. And we both offer small group class options as well, so that you can kind of have supervised exercise ongoing. Thank you for talking to me today, Lewis.
Thanks for having me on.
I hope that's helped some of you out there with osteoarthritis.